Welcome to eMpulse Podcast with your hosts, Doctors Julia Magana and Sarah Medeiros. I am an AI voice. Today's topic is going to be really exciting. I mean, who doesn't love an episode about artificial intelligence and government regulation? Skynet hasn't got a chance.
Welcome back to eMpulse. This is part 3 in our 3-part series on artificial intelligence in emergency medicine.
And now, if you are wondering why do so much on this ostensibly oblique topic, then I have 4 words for you. The future is now. AI is already changing the way that we approach medicine, and it is exciting.
In the first podcast with Dr. Peter Steele, he reminded us that AI is this simulation of human intelligence by machines, enabling them to perform tasks like learning, reasoning, problem solving, and understanding language. It involves algorithms and models that can analyze data, recognize patterns, and make decisions or predictions without direct human intervention. But they are not humans, and they are not there to take the place of human reasoning. He gave us several examples of how that can apply within emergency medicine.
So we can use AI to assist in tasks such as diagnosis, treatment planning, and patient monitoring. Or AI can analyze large volumes of medical data, including images and patient records, to provide insights, improve accuracy, and streamline the healthcare process, and even help us to research.
Dr. Gabe Wardy shared all about the very now application of AI into clinical decision support. The use of AI is exploding in and outside of medicine.
But there are some very serious challenges and obstacles to overcome as well. So today we're going to talk about how the use of AI is rapidly expanding and how regulators are governing this exploding field.
It is important because even if you're not an early adopter, you will want to know how AI is being regulated so we can know when and how it is safe to integrate AI into our own clinical practices.
And fortunately for me, as someone who knows virtually nothing on this topic, we have Dr. Brian Patterson, who is an associate professor of emergency medicine at the University of Wisconsin and is the physician administrative director of clinical AI there.
Welcome, Brian.
Hi, thanks for having me.
That sounds like a really fancy title, but I have never heard of anyone with that title before. Tell me, what does it actually mean?
I am the physician director for clinical AI at UW Health, and I got into that position first as a researcher. My group works on designing and implementing AI-driven clinical decision support tools in the emergency department. But when I took on this role, the goal was to standardize the way that we bring AI tools into use throughout the healthcare organization, and then to start to work on setting up the types of internal regulatory and governance mechanisms that we need to make sure that we're ensuring a safe, consistent product throughout the university. Should mention that here on the podcast, talking to you as a private citizen and emergency physician, not necessarily representing the views of UW Health.
Fair enough. So, Brian, it sounds like you were basically trying to build the plane while you were flying it as you were implementing your own clinical decision tools. And they were like, hey, come on in and help us set up a blueprint.
I think that's a very apt description. Very often the way that you get involved in these types of things is being the first person doing it. And for us, we have been working with AI for quite some time, but I was one of the first from a research standpoint who was trying to actually do things within the health system. One thing we talk about a lot in AI is this chasm between the AI research and what we think models technically can do and how much people are actually doing and studying in practice. And I think it's important for us to keep moving across that gap.
And so do you help other people then that are making clinical decision tools to be able to figure out how to do this well? Or like, what does that job practically look like? And should everybody have a Brian Patterson at their institution?
Well, I think there's a lot of different ways that AI governance is set up. For us, one of the main roles that I have is to help with our committee for AI and predictive analytics. And that's sort of like a pharmacy and therapeutics committee for AI. every hospital has a P&T committee, right, that's going to decide what is safe and what isn't safe to give or what we should be doing. And we've set up this committee to be the same. We look at things that use AI that touch patients, the clinical part of the clinical AI, and we see which things are things that we want to endorse and which things may we be stepping out into an area where there's potentially concerns about model accuracy, concerns about model bias, concerns about workflows that the model may be misaligning, and see if there's things that we want to bring up clinical concerns about.
So, Brian, governance is moving pretty slowly, and AI is moving pretty aggressively. So what are your thoughts on this mismatch?
Well, I think there is definitely a perception of this mismatch. This is something that I get a lot. For me, one of the things that I talk about is this difference with AI between how is AI just like everything else we've ever done and how is AI new, different, and needs to be looked at differently. And this is especially important in governance because hospitals all over the country, one thing we're quite good at is bringing new technologies and new treatments online. You, in your careers as emergency physicians, have seen new things come online. Our hospitals have integrated it. And a lot of governance is how do we leverage that mechanism? We bring new technologies on board and we keep our patients safe and leverage the expertise that we have as hospital systems for doing that while finding those places where AI is special and AI is different. And we need to evolve new governance or new structures to make sure that we're there to react to particular safety challenges that AI creates.
I think that's an interesting point, Brian. And what are some of the unique challenges that we face integrating AI into medicine, not just life and the rest of the world around us?
I think that in general, we have regulatory and privacy concerns that are stronger in medicine than in other places.
Yeah.
I think that's right now we're in a particularly interesting spot with regulatory and privacy concerns. As we've evolved further down the AI implementation road, many of us practice in hospitals that have some AI solutions that are endorsed by hospitals and put into place, and other solutions that are kind of available to us where we can, you can always go to ChatGPT while you're on shift. And you need to be aware of when you're allowed to do something like put patient information in. If you're working in a secure tool that's been given to you by your hospital, vetted, and is a place that you're allowed to put PHI, that's fine. But you can't go and put PHI into, generally speaking, any random website you're pulling up on the internet, or you're going to be violating HIPAA and several other regulations as well. So I think it's important that people understand this regulatory environment as it's getting more complex.
And so who is actually monitoring or governing this process?
Good question. And there's two parts to that. I think governing and monitoring are two different things in terms of whether people know if you're going to be doing something wrong. There's a couple levels to think about regulation. The first is the federal government. And the federal government has three bodies that are particularly important in the oversight of AI tools. People often think about the FDA, and the FDA does regulate medical devices, and software that could diagnose or treat a disease, if AI is being used that way, is a medical device. And the FDA has specific strategies for doing that, but those are going to kick in if you're, say, trying to create a device on your own and then market it to another system, which for a practicing emergency physician may not be as relevant. The other two areas that may be more relevant are there's the Office of the National Coordinator, which certifies electronic health records. AI tools that rather than diagnosing a disease are just sort of part of an electronic health record will have to follow some Office of the National Coordinator regulation. And that's primarily, as opposed to you can or can't do this, it's more about the clarity with which you have to report what you're doing, how you need to tell the end users, which in many cases are the physicians, what is going on under the hood when you're running an AI model. And then the third and arguably most important group that can get down even to the individual level is the Office of Civil Rights. So the Office of Civil Rights might sound like an odd place to go after technology, but they're concerned with discrimination. In the Affordable Care Act, there's a section 1557, that specifically prohibits discrimination within medicine, and OCR takes it very seriously. That's the Office of Civil Rights, that they're going to look into areas where AI could potentially be used, generally not explicitly, but accidentally or incidentally, to discriminate against patients by, mismatching a training data set with the patient population that AI is being used on. There's a lot of ways that AI can create bias. And OCR is concerned about making sure that people who use the tools, down to the levels of health system and individuals, have considered these things when they use the tools.
I really appreciate somebody is asking those questions. That makes a lot of sense, and I'm glad that they're out there. What about hospitals? You obviously have a role. University of Wisconsin has said, we're going to do that. What about on the hospital or on the hospital system levels? And what does that mean for these small little single access hospitals that are out there?
Well, I think this gets back to the how is it different and how is the same, because you can think about two models. One is we have some vigorous central place in the hospital where we really think about AI and we have our expertise put together. And that model, to some extent, is what we're talking about with these committees. The other model would be to regulate AI as it comes up as part of everything else. And this is a challenge that we have, and I'm sure everyone has, which is, as this area explodes, if you say this group's going to regulate AI, are they going to regulate everything or just the AI aspects of things that AI is being added to? Unfortunately, for a while there, it was like we had AI tools and then we had tools that didn't use AI. And now people are sprinkling a little bit of AI into a set of existing tools we have, putting AI into places where it wasn't before. So it seems like it's kind of bubbling up all over the place. And when we think about how your hospital thinks about AI, one thing that we think about a lot is how are we nimble and we keep the expertise where it was in all these other areas, which oftentimes that's the more important aspect of a workflow than the AI portion, and maintain some governance so that we can say the AI portion is something that we do have the expertise to review those specific to AI questions, like, is this a biased model? How is this model performance?
So, Brian, what governing models do you think would work to provide appropriate oversight that allows for safe growth of AI?
From a national level, I think things are moving in the right direction. I think there's this general perception that things have moved very quickly in terms of the capabilities of the AI and that the regulation is behind that. But everything that I've heard from regulators suggests that people understand the work in front of them and they're moving forward as quickly as these government bodies can move to making this happen. I think it's really tough, and I'm glad it's not my problem nationally, to strike the right balance between how do we encourage innovation, because we do think these tools are going to be incredibly helpful in the practice of medicine, and how do we prevent people from doing things that are potentially unsafe. And then to some extent, these technologies are going to be regulated by how many people want to put them into practice. Right now, we're probably at the peak of the, if you guys have heard of the Gartner hype cycle, where you think about any new technology goes through this peak of inflated expectations, and then there's this trough of disillusionment, and then this plane of enlightened use, right? Right now, we're at the peak of inflated expectations. One thing that's really interesting to me as somebody who's been working in this health IT space is people really want to put AI into practice, and they want to do it, and they want to push. And I think in other areas of health technologies, it may be that one aspect of the system wants to push it. Either the clinicians really want it or someone in administration really wants it. In AI, for the first time that I've seen, everybody's on the same page. Like, this stuff is great and we want it. Docs are asking me, when can we use more of this? It's good, but it's also maybe a little scary because some of the normal checks and balances we have to, why do we want this new technology? I think it comes back to finding the specific use cases and not treating AI as some giant bundle that we need to approve or regulate in block, but more to say, we're going to use the useful regulations we have, and we're going to think about each of these use cases separately as some place where we're using AI, and are we really making things measurably better, and are we being safe, as opposed to trying to create giant omnibus. We're going to inform everybody very specifically about every use of AI, rather than thinking about how is the most intelligent way to inform a patient, for instance, about one use case versus another use case.
So if your CEO, COO of your hospital system were to come to you and say, Brian, tell us the model for regulating, for monitoring both of those things inside of a health system, what do you think we should do? What would you say to them?
So I like the structure that we have at UW. I think regulating and monitoring are different, and I'll get to both of them. I think from a regulation standpoint, this idea of keeping the strengths we have in the areas where tools are used, having a strong operational connection with the existing oversight bodies to say, hey, if we're going to do some new AI in cardiology, the people who put new technology out in cardiology should be involved. But then at the same point in time, having a collection of experts somewhere in the hospital who are able to say across the board, this is all the AI we're using, kind of keeping an inventory in case anyone is looking for that. From a regulatory standpoint, you want to know everything that you have in practice. and then making sure that there is sort of a standard. Everyone has looked at each AI model and made sure it's been locally validated. That's really important to make sure things are locally validated, within your system to make sure they work for your patients. So finding some minimum bar before we put AI out and having some group that's responsible for each thing that has AI meeting that bar. And then after that, moving back to that sort of operational capacity. So that's the regulation part. Monitoring is really important. I think it's very easy to set up some set of governance that's going to say, hey, okay, this model is allowed, this model's not allowed, and then just move on with life. But one thing we know is that these technologies change frequently, both from a development standpoint, technologies are getting better, people are changing models, and from an underlying patient population standpoint, where, say we have a model that predicts sepsis really well in the population. We know, and hopefully some of your prior guests have talked about these ideas of like model shift and model drift, where, data drifts away from the original model and maybe it doesn't work so well 2 years after it was implemented. So one thing that we do is at the time of approving a model to say, hey, this is okay and it can go live, we endorse a monitoring plan. And so we have some tools within the health system that we use, and sometimes we have to create custom metrics depending on which AI use case we have, where we say, here's how you thought you were going to move the needle with this model. We need to be able to run some sort of report to see that that needle is moved and that it's continuing to move in the right direction and you're not suffering from these data drift or other things. And then we're going to come back, and depending on the model, that might be something we're going to come back on a yearly basis and take a look, versus we're going to come back at a different interval if that makes more clinical sense.
That sounds like a really comprehensive approach, but also sounds pretty expensive. So has your health system created a way to understand if the costs justify this robust of a governance model?
So I think that we need to think about expense in regards to what's the return on investment that we're getting from these models. And I think you could think about that in terms of how much work is AI saving. So when we think about how we're looking at outcomes, we're not just looking specifically at patient outcomes, but also, we're very concerned with physician workload, well-being outcomes, efficiency outcomes, to see if we're getting that type of return that we're hopefully expecting. Now, most AI use cases tend to be these win-wins where we like to think that we're giving better care to patients, but also that the physicians, nurses, other clinical staff are enjoying their jobs more and finding this to be burden relieving. But that can be a hard balance to manage. I think in terms of specific return on investment can be difficult to calculate depending on where you're at. Certain groups spend a lot more time or a lot less time really trying to crunch numbers to get ROIs.
Okay, let's look at the legal liabilities to the system and to the individuals. When we are relying on, let's say, AI for diagnosis or treatment decisions in emergency cases, who is liable for the use of AI if it goes awry?
So I think my short answer is don't rely on AI for it. I think that's definitely the case where we're at right now. One thing we talk about a lot is how you should view AI in your practice and the interplay between effective AI governance and effective AI literacy. In technology governance, when we talk about like clinical decision support, one thing that we talk a lot about is making sure that decision support output is very safe, right? That a decision support tool is only going to give you a recommendation that couldn't possibly cause harm. In the AI space, especially with generative AI, where we're asking these tools to sort of like generate options for us, oftentimes by making them perfectly safe, we make them much less useful than if we give them a little bit of time to be creative. But it's scary from a governance standpoint because to do that, we have to have more of a contract with our end user that's saying, hey, you've done a little bit of homework as to what this thing can do for you, and you're not going to just use it willy-nilly. And the analogy that I always go back to is this idea of a crystal ball versus a co-pilot. I think often we have this heuristic of a crystal ball that we love to throw new technologies in. It's just when somebody gives us something new, we like to think of it as the answer, right? And if you're looking at your crystal ball and it's going to give you the answer, it's a pretty dangerous heuristic for AI for a couple of reasons. So first of all, if you look into a crystal ball and it gives you the wrong answer, you might trust it and do something really bad. Second of all, if you look into a crystal ball and it gives you the wrong answer, you're not going to keep looking at that crystal ball. You'll probably throw it away. And both of those are really damaging to the adoption of AI. I hear a lot of people talk about how can we increase trust in our AI tools? And I always say, I don't think that's actually our goal. We don't necessarily want people to blindly trust these tools. A better analogy is this idea of a co-pilot, where you think about the AI as another member of your team, somebody who has a different set of skills than you, but a different set of weaknesses as well. And I really don't like anthropomorphizing AI too much and saying it's like a human member of your team. This is a non-human member of your team. And this AI tool is going to potentially give you some insights that you didn't have an easy way of seeing, but it's also going to have glaring blind spots. And if we think about having a co-pilot on our team, that's actually not that far from how we think about a lot of things in medicine, right? We all work in, multidisciplinary teams in healthcare. And when somebody tells me to do something, a consultant, an intern, some other person in the hospital, I don't necessarily blindly trust them like they were the crystal ball with the answer. I integrate that input into my own plan of care. And I think using AI the same way is really important. And effective governance is really built on effective literacy.
So, Brian, where does consent fit into all of this?
I think this is a really good question. There are a lot of discussions around when we should be telling people we're using AI and how should we be telling them. From my standpoint, there's no one-size-fits-all solution. We use AI in so many different ways, and it's very easy to get on a podcast and say, every person should know every time AI is being used in their care, hard stop, and they need to know it before they do so. The concern with that approach is I don't know if it integrates all that well with medicine as it's being practiced and as it's been practiced. There are some areas where consent before AI is used is very important. For instance, ambient note listening, where we're recording a patient conversation, then we're going to use that to generate the note. Generally speaking, from a legal standpoint, I don't even know if it's legal to record someone without consenting their voice. So you're going to tell your patient, and it makes sense. And in places where AI is a brand new workflow, where we're going to do something new with data that we've never done before, that's going to affect treatment, certainly some sort of, prospective, hey, we're going to do this thing makes sense. Then the next level of consent down is this idea of watermarking perhaps a message that was generated with AI is something that some organizations do. But even that is something that the implications run in both directions. So I think it's important for people to know, if they're interacting with a robot without human interaction. But there's some sort of spectrum between talking to a chatbot and a human being using AI to kind of set up their response and sending that on to a patient. I don't know if you guys have ever used a large language model to help you draft an email to a colleague. I do sometimes, and I don't necessarily say, hey, I had ChatGPT help me make the wording a little bit more Midwest nice when I sent you this email. And the reason for that is an ownership reason. So I think one of the downsides to creating a situation in which we tell everybody we're using AI all the time is we don't want people slapping it on as a disclaimer, right? So if you would imagine that if you have some communication where you're helping a patient and we say, hey, I used AI to help me, does that mean the physician's going to spend a little bit less time reviewing it, a little bit less time saying this is my work? So we need to balance these ideas of ownership versus some dangers of people not knowing what they're interacting with or some dangers of automation bias. As I said, I don't think anybody wants a world in which people aren't sure if they're communicating with a human or a robot. It's just we're evolving this understanding of what is it to communicate with a human. When you use a tool to help you, how much of a tool do you use before it's not yours anymore? On the spectrum from Grammarly to full drafting.
Yeah. And I mean, also to use that on a clinical application, like I don't consent my patients before I use the PCARN TBI rule. I don't ask them, is it okay for me to tell you what your probability of a head trauma is, clinically important brain injury is? So where does this fit into this as we're using tools,
It gets even stickier here, in this area of MI with say I'm using a machine learning model that scans your data every 5 minutes and gives me a score of how likely you are to develop sepsis. Like, how could you possibly prospectively tell a patient you're going to do that? And if you do look at that tool and then decide to order a lactate on this patient, how much of that decision-making is the AI and how much of it is your other decision-making? And how best should you ethically inform that patient of your decision-making? And sometimes I wonder, I've certainly heard people talk about in this abstract case, and it always sounds good to say, oh yeah, a patient should definitely be informed. But now we're talking about codifying these things into legal requirements. And I wonder if these folks have ever seen us talk to a patient about, say ordering a CT scan after they were in a car accident. I think we have a real space here where we need to make sure that the regulations, as they evolve, protect patients and make sure that people are aware of what's going on in their healthcare, which is, of course, extremely important, but also that we do it in a way that's rational and doesn't result in some giant manifest of AI tools being presented to each patient as they enter a hospital, they just have to sign off on before things go forward.
Yeah, which is why I'm glad that there are clinical physicians in AI directorships like you, Brian, to help us kind of navigate that piece, because I certainly don't want a checked box of tools that I have to get consent for before helping me make good clinical sense and decisions.
One of the things that concerns me is, what if I don't follow what AI says? So, what if AI suggests a treatment and I, as a clinician, decide not to do that? What's the liability there?
This is a question I've gotten a lot. I think this is something that people get worried about in all aspects of decision support. And I think it's evolving. It's also a question we get with a lot of new technologies. We often switch from, am I going to be liable for using this thing, to am I going to be liable if I don't use this thing? I certainly don't think we're there yet with AI, but I would say that if you designed or if you trust an AI tool enough to interact with it clinically, I wouldn't necessarily say you're beholden to take its advice, but you need to at least think about what it says. I think in other areas, we've seen utilization creep up when more things get suggested, and that's something we're going to have to watch as these tools get put out, because one thing we don't want them to lead to is over-testing. Now, on the liability side, there's also a lot of, how long are we going to store AI-specific recommendations when something gets put in front of you? Is that something that's going to be sitting there in the chart for the patient to take a look at? And, even if it was a terrible recommendation, if somebody sees it, that could lead to bad outcomes. So that's something that individual hospital systems think about a lot when they work on rolling these tools out, is who's these results going to be visible to? How long are these results stored in the system? What are the applicable regulations there?
Okay, we've talked a lot about governance and monitoring. What do you suggest to the average emergency medicine physician that they do with this knowledge today? Like, what does this mean for me tomorrow at my 6 a.m. shift?
My big push is always to engage with these technologies. Like I said, good governance is going to rest on good literacy, and good literacy is going to breed good governance and good tools coming down the road. So I think as a physician, if when you're interacting with these tools, when people are telling you about them, you're asking the right questions, like, how is this being disclosed to my patients? What are my responsibilities with regards to privacy around these tools? And that you understand the environment you're working in. I think these tools are going to add so much value, but in this very early period, it can be really convenient to say, hey, I'm just going to put my head down and go to work and wait for somebody else to figure this out. I think these things are so powerful that somebody is going to figure them out. And I'd rather it be a group of engaged emergency physicians who are doing the work than for us to totally outsource this to some group of folks with no medical background whatsoever who come in with some cost-saving measure in 5 years because we didn't engage when we had the chance to.
Well, that would not align with how emergency medicine as a specialty works anyways.
Brian, what are you most excited to watch for in terms of AI in emergency medicine?
So right now, in the very short term, I think there's a lot of cool tools that are being used in other areas of medicine that have been very limited in their introduction into emergency medicine so far. I think a lot of us have heard about ambient listening. I've certainly seen that used in primary care offices, and I've talked to emergency physicians who are using it in the emergency department. There are a lot of reasons why you could think it might be harder to do, but everyone who I've talked to who's using it is saying, no, this is great. It saves me so much time. I don't write notes. Other areas where we generate a lot of text, you could imagine, discharge instructions, where we could have AI kind of help us with just the pros and getting these things up. Like on my last overnight shift, I was thinking about this, how much time I spend just kind of like typing out various discharge instruction things that it would save me a ton of time. I think as we get a little bit further out, the ability of AI to gather evidence and give us recommendations is really impressive. I don't know if you guys have tried openevidence.com, but it's not perfect. I've gotten it to make mistakes, but its ability to point you in the right direction from literature is pretty impressive if you take a look at open evidence compared to, say, just Googling for something that you want to use. And I think what we're going to see over the next couple of years is ways in which we can get AI output to be safer with regards to information retrieval, so that we solve this problem where it's not able to give you a wrong answer, where we can strain it to keep it safer, such that we can get really useful clinical advice and clinical decision support that really takes that promise of, I'm going to look through the whole medical record, get your patient-specific information, combine that with the most up-to-date recommendations, and help you in terms of what the best treatment for your patient is. I think medium term, the other thing that I'm really excited about is summarization. So we've done some research looking at the amount of information that we go through every time we see a patient. The amount of notes that an emergency physician reads in my emergency department has gone up an incredible amount within the past 10 years. Just as we have medical records for longer, we're gathering more information on our patients. But your average patient now has more than a novel's worth of notes that we need to sort through. And any one of those could have some like really important pearl for your ED visit. And I don't know about you two, but when I'm on shift, I find myself really frustrated when a patient with a huge medical record comes in and I've got to spend like 5 minutes looking through all their notes before I talk to them. We're already looking at AI tools that are going to try to summarize these, bring out the key points, and bring them back.
Yeah, that sounds amazing. And I mean, I think that's my next question is like, how do you see on a practical level AI evolving over the next 5, maybe 10 years in the emergency department? Like, are these things that you're looking forward to going to happen in that time frame?
I would say that most time-bound predictions that I've made over the course of the past 5 or 10 years on AI have been flat out wrong. So I'll just lead with that. I think things are moving really quickly. Right now, AI is really good at generating text. It's really good at summarizing. And there are ways to get it really good at information retrieval. But making recommendations that we know are always consistently within a certain envelope of not going outside and saying something that could hurt somebody, that I think is a longer term question. And I'm excited to see how that evolves. The idea of training models to act like various agents, as we call them, the people that we would normally talk to on a given clinical shift, and getting expertise to add more people to your virtual team, I think is really exciting. And I think that's a little bit further down the line. I wouldn't expect anybody to be rolling that out in the next little while, but this is where I've often been wrong. For all I know, we're going to hear about it going live somewhere next week.
You know, I walked around the ASAP exhibit hall and it was like every third booth has like AI something or another. So, I mean, I am obviously not good at predicting any of these things and have no expertise in this, but it does look like the future is now. And a lot of these things that we're talking about are here or on the horizon very soon.
Yeah, it seems like we're leaping forward very quickly. With all the hype around AI is also a lot of legitimate interest. And so many people are pouring so much development time, resources, and effort into this that if it was moving fast before, it's moving even faster now. And I think we're going to see a lot more, both in medicine and outside of medicine, real drastic changes as these things become more and more just part of our daily lives.
Yeah.
So, Brian, for us, your colleagues, what should emergency medicine physicians be focusing on in terms of learning about AI to stay ahead of the curve or even just to keep up?
I think there's sort of two ways to think about it. One is AI in medicine, and the second is AI in general. There is just a ton of AI tutorials, AI newsletters. It's really easy to get lost in this kind of churn of not really newsworthy news that comes out. I like to try to stay up to date on what's going on in the non-medical world, because there's been this tendency for things that go on non-medically to sort of influence what's going to happen in medicine. Because of all our regulatory concerns, it always takes a little longer to do everything in medicine. So I think, continuing to get yourself understanding how these large language models work is one of the biggest things. And the easiest way to do that is to play around with them, use them in other aspects of your life. Whether it's GPT or Google's Notebook or some other tool, that could be really useful in understanding like the inherent abilities and limitations of the models. I've really been enjoying playing around with the Google. It's notebooklm.com.
Oh, I just opened that one too.
Okay, you'll enjoy this as podcasters. Have you done the...
Yes!
If you put a paper in and have it make a podcast, it's pretty good.
It is fantastic. I just did that for a module that I'm working on for child abuse, and it was a really fun way to break up that module.
Yeah, so I like playing around with things like that to see where things are going. Within medicine, I think looking at some of the medical tools, but again, being careful. Like I said, I've been looking at openevidence.com, which is a cool large language model backed tool that brings papers to you that answer questions. And I think in my experience, it's worked better than like sort of more general AI tools, which I've tried to get to do the same thing. And then I use GPT for a lot of things. I try to push myself to like learn new workflows using GPT. It's pretty easy to just go about business as usual. And the first couple times you use GPT to maybe help you with an email or maybe try to like organize some text for a document or set something up, it might be like more work than it's worth. But if you do it 3 or 4 times and you try to get better at it, you'll see how much value these things can add. And then on the medical side, I mentioned open evidence. And then the other thing is the actual medical literature. I think the journals that are showcasing big movements forward in AI are still very authoritative sources for looking at this stuff. And maybe it's not the first place to hear about something, but it's definitely a good place where you're going to hear good information. There's the New England Journal AI, NAJM AI journal is a good place to look up, kind of what's going on in AI. Nature Digital Medicine publishes a lot of AI articles. And you'll start to see more of it in the emergency medicine specific literature as well.
Well, that sounds like a fantastic source to end on.
Well, thank you guys so much for having me.
Well, that was a lot of AI.
Yes, it was.
But I personally feel better informed and ready for that future of now.
Yeah, I mean, if you have not heard the last 2 episodes, I encourage you to go back and learn with these leaders. I think they did a fantastic job of breaking it all down.